Welcome everyone. Today we will discuss malignant epithelial tumor of penis, which is squamous cell carcinoma. The majority of malignant tumor of the penis are squamous cell carcinomas originating in the mucosal inner lining of the glans, coronal sulcus and foreskin. Because squamous cell carcinoma of skin of the shaft are vanishingly rare, and there are no report of tumor arising in the outer skin of the foreskin. And this clear anatomical distinction is important because penile carcinomas originate in the mucosa, not from the skin. And out of various subtypes, this usual squamous cell carcinoma accounts for about half of all carcinomas. So now coming to histological classification of penis, which is based on clinicopathological distinctiveness and relation with human papilloma virus. They divided as non-HPV related penile squamous cell carcinoma and HPV related penile squamous cell carcinoma. Non-HPV related penile squamous cell carcinomas are squamous cell carcinoma usual type, pseudohyperplastic carcinoma, pseudoglandular carcinoma, verrucous carcinoma, carcinoma cuniculatum and papillary carcinoma NOS, adenosquamous carcinomas, sarcomatoid carcinoma and mixed carcinoma. HPV related penile squamous cell carcinomas are basaloid, papillary basaloid, warty carcinoma, warty basaloid carcinoma, clear cell carcinoma, lymphoepithelioma like carcinoma and other rare carcinoma. These carcinoma usually occur in the 5th to 6th decade of patient life. Some familiar cases have also been noted, but there is no racial predilection and there is a wide geographical distribution with low incidence rate in the USA and Europe and high rate in South America, Africa and Asia. And the incidence rates has been slowly decreasing in some countries, but HPV related tumor appear to be increasing in other countries such as USA. So what are the risk factors associated with penile carcinomas? The risk factors are lack of circumcision, phimosis, chronic inflammation, lichen sclerosis, smoking, radiotherapy, ultraviolet radiation and a history of common wart and multiple sex partner and commonly with long phimotic foreskin. So what is the role of HPV in case of penile carcinomas? HPV is also detected in most basaloid, warty basaloid variant of penile intraepithelial neoplasia, and it is consistently negative in differentiated penile intraepithelial neoplasia. So, most of the carcinoma associated with HPV are warty basaloid and warty carcinomas, where usual type of carcinomas are negative for HPV. Well differentiated carcinoma will be negative for HPV. So, which HPV genotype is associated with penile carcinoma? Is HPV 16 is the most common genotype associated with penile carcinoma. The gold standard for HPV detection is PCR, but P16 immunostaining is a useful surrogate in place of PCR. So, we can use P16 IHC to identify HPV. The presence of HPV is considered a good prognostic marker in some series but not in other. Now coming to location of squamous cell carcinoma of penis. Squamous cell carcinoma can involve any part of penis and may involve more than one site. The glans penis is the most common site of origin and involvement followed by foreskin, coronal sulcus and shaft. Patient with tumor of foreskin have a better survival rate than patient with tumor of other anatomical site. So, foreskin associated with better survival than other site like coronal sulcus, shaft. Now coming to clinical feature. The tumor may present in several ways, although the most common is a gross abnormalities, discrete mass, ulcer and erythematous lesion noticed by the patient in the glands or the foreskin. Pain, bleeding, dysuria are unusual in penile squamous cell carcinoma. Occasionally, a patient presents with phimosis with discharge or adhesion. Patient may present late, even in country with well-developed medical services, and may have urinary obstruction due to urethral involvement, large pinoscrotal masses, fistula, or inguinal metastasis. In patient with long foreskin and phimosis, the tumor may be concealed and inguinal metastasis may be presenting sign with disease recognized secondary to identify of lymph node metastasis. Rare neoplasms have occurred in a patient with HIV, and these neoplasms are usually associated with HPV associated subtype. So what is the role of imaging in penile squamous cell carcinoma? The role is limited. MRI is the only imaging modality of value for assessing the local extent of primary tumor in the penis, like in evaluation of status of inguinal lymph node. So, detection of inguinal lymph node is the main target in imaging. Tumor spread may be local or systemic. Local spread can occur from one epithelial compartment to the other and from superficial to deep anatomical level. Typically, tumor of glands spread to coronal sulcus and foreskin, and foreskin neoplasms spread to the sulcus or glands. Spread may be horizontal or vertical. Horizontal spread is typically of superficially spreading invasive or in situ carcinomas, and vertical spread is typical of basaloid and sarcomatoid high-grade poorly differentiated squamous cell carcinoma. The urethral epithelium is particularly prone to such spread and is a common site of positive surgical resection margin. One more important route of spread is the penile fascia, which is another common site of positive resection margin. In this, extension to the fascia occur directly from the foreskin or through the coronal sulcus. A tumor invading the fascia may penetrate vertically into the shaft via blood vessels and adipose tissue, traversing the tunica albuginea. Occasionally, particularly in locally advanced cases, the tumor may spread within the organ in a nodular manner as a satellite nodule, usually in a erectile corpora. And one more important point is there is a fairly predictable sequential pattern of local, regional and systemic dissemination of penile carcinoma. Initially to superficial inguinal lymph node, particularly the sentinel lymph node, then to deep inguinal, and after that pelvic lymph node, and in the last the periaortic lymph nodes in the retroperitoneal region are involved. So the sequence is superficial inguinal lymph node to deep inguinal lymph node, and then pelvic lymph node, and in the last periaortic lymph node. Direct metastasis to pelvic lymph node, also known as skip metastasis, is unusual, very unusual. Systemic metastasis occur as a late event. And what are the site of systemic metastasis? As seen in autopsies, are liver, retroperitoneal and mediastinal lymph nodes, lung and heart. Now coming to non-HPV related squamous cell carcinomas. So first subtype is usual type. This is an invasive epithelial neoplasm with various degree of squamous differentiation and keratinization. This diagnosed after the exclusion of other histological variants. So this is a diagnosis of exclusion. You have to exclude other subtype and then diagnose this type. In this type of tumor, we grade these tumor like grade 1, grade 2, grade 3. Grade 1 is well differentiated squamous cell carcinoma, grade 2 is moderately differentiated squamous cell carcinoma and grade 3 is poorly differentiated squamous cell carcinoma. So, as in this picture A is showing grade 1 tumor, reveals multiple well delineated invasive tumor nest composed of well differentiated squamous cells. This picture B is a high magnification of well differentiated squamous cell carcinoma grade 1, showing cells with ample eosinophilic keratinized cytoplasm and round to oval nuclei with minimal atypia. Picture C and D is showing moderately differentiated usual type squamous cell carcinoma penis, showing irregular nests of tumor cell with keratinization and nuclear atypia. D picture is the high power of moderately differentiated squamous cell carcinoma, showing nest with perineural invasion. Now coming to grade 3, poorly differentiated usual squamous cell carcinoma. Image A is showing invasive tumor with angulated nests, poor keratinization, hyperchromatic nuclei and marked stromal reaction. Image B is showing most cells which are atypical and there is a focal keratinization. Image C is showing solid tumor with focal keratinization and the cells are large with cytoplasm range from scant to ample and the nuclei are irregular and pleomorphic in which mitosis are apparent. So what is the prognosis and predictive factor of usual type of squamous cell carcinoma penis? This is a high grade deeply invasive tumor carcinoma. The biological behavior of usual squamous cell carcinoma depend mainly on histological grade, depth of infiltration and whether there is a vascular or perineural invasion is present or not. If grade is high, tumor is infiltrating very deep and there is a vascular perineural invasion is associated with poor prognosis. And the outcome of patient with metastasis to a single inguinal lymph node is similar to that of patient with no metastasis. But there is a gradual increase in mortality with increasing number of lymph node involved with metastasis. High node density is related to adverse pathological factor and high mortality rates. So this is all about usual squamous cell carcinoma penis. Now coming to second, pseudohyperplastic carcinoma. This is also a subtype of non-HPV related squamous cell carcinoma. So this pseudohyperplastic carcinoma variant is a multifocal, extremely differentiated squamous cell carcinoma of older patient and this commonly associated with lichen sclerosus which simulates pseudoepitheliomatous hyperplasia. So these usual penile neoplasms are associated with a specific constellation of clinicopathological features which are multifocality. So these tumors are usually multifocal and these tumors usually occur in older age, more than 70 years of patient. This tumor is usually associated with lichen sclerosus, and this usual site of involvement is foreskin. So, as these tumors are multifocal, several biopsies may be necessary for a cancer diagnosis. Tumor with other histology like verrucous papillary histologies are often present in the same specimen. As shown in this diagram, this is a diagrammatic representation of circumcision specimen associated with multiple histology in a same specimen like pseudohyperplastic carcinoma showing in yellow color and verrucous carcinoma showing in light blue color. This diagram is showing pseudoepitheliomatous hyperplasia in green color, papillomatous verrucous carcinoma and a pseudohyperplastic carcinoma associated with lichen sclerosus in orange color. So, this tumor is multifocal, associated with multiple histology, and this is a part of well differentiated histology. Now coming to histology of pseudohyperplastic carcinoma. In this kind of tumor, there is a downward irregular proliferation of squamous nest with sharp border and little stromal reaction. The cells are extremely differentiated and minimal or no atypia. Stromal reaction surrounding invasive nest may or may not be present. Pseudoepitheliomatous hyperplasia, papillary carcinoma, NOS or verrucous carcinoma may be present in the same specimen. There are usually changes of differentiated penile intraepithelial neoplasia and lichen sclerosus adjacent to invasive tumor. Now coming to prognosis and predictive factor. These tumors are usually grade 1, superficial and usually not associated with PNI and LVI, perineural invasion and lymphovascular invasion. Now coming to third entity, pseudoglandular carcinoma. This is also a subtype of non-HPV related squamous cell carcinoma of penis. The pseudoglandular carcinoma variant of squamous cell carcinoma is an aggressive tumor with prominent acantholysis and formation of pseudoglandular spaces. These tumors present in a patient which are typically in their 50s and present with distal penile mass and present as distal penile mass. The tumor is irregular form and whitish grey with ulceration. This tumor gives typical honeycomb appearance and showing spaces which are partly filled with necrotic debris. These spaces lined by atypical cuboidal or columnar cells. Most of the tumors show the histology of a poorly differentiated squamous cell carcinoma. However, in some cases, vacuolization is present in otherwise solid nest of carcinoma. Some cases resemble like a angiosarcoma because of honeycomb appearance and spaces filled with necrotic debris. Atypical cuboidal or columnar cells gives appearance of angiosarcoma. One more important point is previously this tumor also known as Ackermann tumor, showing low power of the tumor in which the tumor has a honeycomb appearance due to acantholysis. In picture B, this is showing superficial focal pseudoglandular pattern in an otherwise typical squamous cell carcinoma. In picture C, there is a pseudolumina give the impression of glandular tumor, and there is perineural invasion is also noted in picture C. Image D is showing the tumor with adenoid feature along with intraluminal necrotic debris. Now coming to verrucous carcinoma. Verrucous carcinoma is an extremely differentiated keratinizing papillomatous and acanthotic neoplasm characterized by broad-based pushing interface of tumor and stroma. This is a long-standing tumor affecting patient in the 6th or 7th decade of life. The precise incidence is difficult to estimate due to misinterpretation in the literature of condylomas, papillary carcinomas and Vati carcinoma as a verrucous carcinoma. Lichen sclerosus is a commonly associated condition as are differentiated penile intraepithelial neoplasm and verrucous epithelial hyperplasia. Verrucous carcinoma account for 2 to 3% of penile squamous cell carcinoma. Macroscopically, the tumor has an exophytic pearly white multinodular and cobblestone appearance, and the cut surface of partial penectomy shows an exophytic white papillomatous tumor involving glands, coronal sulcus and foreskin. This verrucous carcinoma is very well differentiated with a sharp delineated at the tumor stroma junction. Normally, the tumor front is broad based and pushes rather than infiltrates subepithelial and deeper tissue, making diagnosis of invasion difficult, particularly in the small biopsy. There are intraepithelial cyst and plaque formation, and the cells are extremely differentiated with minimal deviation from the histology of normal squamous tissue. Normally, nuclei are bland, round, vesicular and very small. However, slightly atypia may be noted at the basal cell layer. Coelocyte is absent in these kind of lesion. A few clear cells on the surface but without the diagnostic feature of coelocyte may be noted, and foci of detached tumor may be superficially invasive in the lamina propria. Now coming to prognosis, this is a slow growing tumor that may recur locally but metastasis does not occur in typical cases. Recurrence is reported in about third of cases, usually because of incorrect pathological classification as a benign neoplasm or due to insufficient surgery. So this is all about verrucous carcinoma. Now coming to carcinoma cuniculatum. Carcinoma cuniculatum is a variant of verrucous carcinoma. It is a verruciform low-grade neoplasm with a characteristic labyrinth growth pattern reminiscent of rabbit burrow. That's why name taken as cuniculatum, which is a Latin word for rabbit, similar to tumors originally described in the foot. This is a long-standing tumor of men in their 7th to 8th decade of life. Multiple anatomical compartments are usually affected, but glands involvement with deep penetration into both erectile corpora is typical. Macroscopically, cut surface shows an exophytic superficial tumor in the glands with minimal involvement of lamina propria in the dorsal aspect. These kind of tumor, usually well differentiated endophytic papillomatous tumor with focal surface opening. The tumor growth pattern is similar to that of verrucous carcinoma but with a major endophytic component. There is hyperkeratosis, papillomatosis and acanthosis as well as pushing broadly based margins. Growth is predominantly endophytic. Foci of irregularly invasive low-grade squamous cell carcinoma may be present. The cells are extremely well differentiated and no coelocytes are identified. They are sinus tract, which on tangential cut may simulate epidermal cyst containing hyperkeratotic material. This tumor may recur, but despite invasion of erectile tissue, which is present in 1/3 to half of all cases, nodal metastasis and mortality rate are low. So this is all about carcinoma cuniculatum. Now coming to adenosquamous carcinoma. Adenosquamous carcinoma are squamous cell carcinoma with mucinous and or glandular features arising from the surface epithelium. The clinical features are similar to those of usual squamous cell carcinoma. This carcinoma usually arises in 50 to 60 year of age, and the preferentially affected site is the glans, but extension to coronal sulcus and foreskin is common. The tumor origin may be related to misplaced periurethral or metaplastic mucinous gland. Adenosquamous carcinoma is a mixture of neoplasm with squamous cell carcinoma and adenocarcinoma feature. These features may be separate or more commonly intermixed. The glandular component is mucinous and usually minor, grouped in one field or intermixed with the squamous carcinoma cell. The glands are lined by cuboidal or columnar epithelium, and in this tumor, immunostaining for carcinoembryonic antigen is positive in the mucinous component of the tumor. But there is a limited experience with these neoplasms. They recur locally in 0 to 25% of patients. Inguinal nodal metastatic rate range from 43 to 50%, and mortality rate is low, ranging from 0 to 14%. Now coming to sarcomatoid squamous cell carcinoma penis. Sarcomatoid squamous cell carcinoma is an aggressive large tumor predominantly composed of spindle cell with at least focal histological or immunohistochemical evidence of squamous differentiation. The spindle cell component must constitute of at least 30% of tumor to quantify for this diagnosis. This unusual tumor accounting for 1 to 4% of all carcinoma of penis and preferentially affect the glands of penis in the 6th decade of patient life. Identifying tumor location in the glands is important because it may be the only clue to separate sarcomatoid squamous cell carcinomas from sarcomas, because sarcoma usually affecting corpora cavernosa at the level of penile shaft. A history of slowly growing mass with a recent rapid enlargement and ulceration is typical in these kind of tumor. Patient may present initially with regional and systemic metastasis. These kind of tumor arise de novo usually in association with other squamous tumor types after recurrence of a usual squamous cell carcinoma or secondary to sarcomatoid transformation after radiation therapy. So these kind of sarcomatoid squamous cell carcinoma may arise de novo or may arise after radiation therapy. Grossly, sarcomatoid squamous cell carcinoma are ulcerative and hemorrhagic, fungating or polypoidal masses, cut surface of which show a deeply invasive grey or dark reddish necrotic and hemorrhagic tumor. Microscopically, sarcomatoid carcinoma shows a biphagic carcinomatous and sarcomatous spindle cell tumor, showing hypervascularized, poorly differentiated tumor simulating an angiosarcoma, pleomorphic and spindle strap-like cell resembling rhabdomyosarcoma. So, sarcomatoid carcinoma composed by atypical spindle cells arranged in fascicle or bundle with or without foci of carcinoma, sometimes admixture of pleomorphic epithelioid or giant cell. The morphological features are similar to those of fibrosarcoma, leiomyosarcoma, angiosarcoma, fibrous histiocytoma, rhabdomyosarcoma, malignant melanoma. In these kind of tumor, necrosis is prominent and there are numerous mitosis. The tumor has the potential to differentiate into muscle, bone, cartilage as a benign or malignant one. In these kind of tumors, cytokeratin, 34 beta E12 and P63 immunostain are good epithelial marker for sarcomatoid squamous cell carcinoma. Now coming to prognosis and predictive factor of sarcomatoid squamous cell carcinoma. Sarcomatoid squamous cell carcinoma is the most aggressive of all penile neoplasms. Adverse pathological prognostic factors such as high grade deep invasion of erectile tissue, vascular invasion and perineural invasion are present in this type of tumor. Recurrence occur commonly and inguinal metastasis is seen in about 80% of cases. Mortality varies from 45 to 75% and most patients die from disease within 1 year after diagnosis. Now coming to mixed squamous cell carcinoma. Mixed squamous cell carcinoma contain morphological feature typical of 2 or more variant of squamous cell carcinoma in the same specimen. This occur commonly in 7th decade of life and constituent 1/4 of all penile squamous cell carcinoma. Most tumors are located in the glands, but the other site may also be involved. Now coming to papillary carcinoma NOS. This is a papillomatous verruciform low-grade keratinizing neoplasm without coelocytosis, diagnosed after excluding verrucous and Warty carcinomas. This tumor affects patient in the 5th to 6th decade of life, usually associated with lichen sclerosus. They vary in size from small to 14 cm. These tumors affect the glands, but other sites may be involved in this kind of tumor. Now coming to histology, these carcinomas are well differentiated, hyperkeratotic and papillomatous lesion. The papilla are variable and complex. Irregular fibrovascular core may be present, but without coelocytosis. Squamous cells are maturing with minimal to moderate nuclear atypia. The interface of tumor and stroma is irregular. Cell differentiation is present even in deeply invasive tumor foci. Papillary carcinoma NOS is considered a non-HPV related tumor. Immunostaining for P16 is usually negative in this kind of tumor. This tumor may recur after despite invasion of erectile tissue, present in 1/3 to half of all cases. Nodal metastasis and mortality are low in papillary carcinoma penis. Now coming to HPV related squamous cell carcinoma, these are high grade carcinoma associated with poor prognosis. First is basaloid carcinoma, is a solid, aggressive, HPV related tumor characterized by downward solid proliferation of basophilic cells resembling basal cells. The median patient age at presentation is in the 6th decade of life. Basaloid carcinoma account for 5 to 10% of all penile carcinomas. It is most commonly arise in the glands, but cases originate in the foreskin have also been reported. In developing countries, more than half of patients present with regional metastasis. Macroscopically, basaloid carcinoma present as a flat, ulcerated, irregular mass, the cut surface of which characteristically show a solid, tan, deeply invasive tumor with predominantly endophytic growth. Multiple foci of yellowish necrosis within the tumor may be present. Basaloid squamous cell carcinoma show a downward proliferation of closely packed solid nest of basophilic cell. Most of the solid nest show central necrosis. Basaloid squamous cell carcinoma show a downward proliferation of closely packed solid nest of basophilic cell, often with comedonecrosis, central necrosis like features. Separation artifact may be seen surrounding tumor nests. The cytoplasm is scant and nuclei are basophilic, small to medium sized and oval to round, with inconspicuous nucleoli. Mitosis and individual cell necrosis are common. Central abrupt keratinization may be present. Peripheral palisading is uncommon. Basaloid squamous cell carcinoma mostly show a starry sky appearance due to apoptosis and spindle cell features. A diffuse and trabecular small cell pattern may simulate neuroendocrine carcinomas. Stromal hyalinization and basement membrane-like material may be noted. Vascular invasion is common and may involve periurethral lymphatic vessels. Basaloid carcinoma is an HPV-related penile carcinoma. The immunostain of P16, which is a surrogate marker for human papillomavirus detection, is positive in most cases. Human papillomavirus 16 is the most common genotype detected by PCR in basaloid squamous cell carcinoma. Basaloid squamous cell carcinoma are an aggressive tumor characterized by high histological grade, deep invasion into corpora cavernosa, frequent vascular and perineural invasion, and inguinal lymph node metastasis in more than half of the cases. In basaloid squamous carcinoma, rates of local recurrence is high, particularly in a patient treated with partial penectomy. Mortality varies from 21 to 67% depending on the completeness of primary treatment or the clinical stage at diagnosis. Now coming to papillary basaloid carcinoma. Papillary basaloid carcinoma is an exophytic or exoendophytic papillomatous HPV-related penile neoplasm composed of small basophilic cells resembling urothelial tumor. It is a papillary variant of basaloid carcinoma. Papillary basaloid carcinoma have a central fibrovascular core resembling those in condylomatous or urothelial tumor. The tumor is composed of small uniform basaloid cell. Papillary basaloid carcinoma is papillomatous and invasive, and their invasive component is similar to basaloid carcinoma. These tumors usually diffusely stain for P16. Papillary basaloid carcinoma is a non-invasive purely exophytic tumor, shows hyperkeratosis and papillomatosis. The papilla are condylomatous with a central fibrovascular core. The tumors are composed of uniform small basophilic cells, and these kind of tumor near meatus may be confused with urothelial neoplasm. Like in other HPV-related neoplasms, the immunostain for P16 is usually strongly positive. The HPV P16, the human papillomavirus 16, is the viral genotype most commonly detected using polymerase chain reaction (PCR). The distinction from urothelial papillary carcinoma depend on GATA3 stain or uroplakin, which is negative in papillary basaloid carcinoma. The prognosis of papillary basaloid carcinoma is related to the proportion of the invasive basaloid carcinoma component and tumor depth of invasion. Tumor with deep invasion and more basaloid carcinoma component associated with poor prognosis. Now coming to warty carcinoma. Warty carcinoma is an exophytic and papillomatous human papillomavirus related tumor resembling typical condylomas but with malignant cytological feature. Previously, warty carcinoma, also known as condylomatous carcinoma. The median patient age is in the 5th decade of life. Warty carcinoma account for about 5 to 10% of all penile carcinomas. They are slowly growing lesion, often present several years before diagnosis. Warty carcinoma involve glands, coronal sulcus, and foreskin. These tumors are typically cauliflower-like exophytic large neoplasm. The surface has a white to tan flat cobblestone, micronodular to macronodular in appearance. The cut surface is characteristic and diagnostic. There is an exophytic papillomatous multinodular pattern, each nodule consisting of a papilla with a dark central fibrovascular core surrounded by a thick white to tan tumor rim. Grossly, the boundary of the tumor and stroma appear well demarcated. Grossly and externally, warty carcinoma is a micronodular tumor affecting foreskin with partial extension to glans. The cut surface shows an exophytic papillomatous tumor corresponding foreskin and glans. Now coming to histology of Warty tumor. Warty carcinoma shows a long condylomatous papillae with a prominent fibrobascular core burrowing into underlying lamina propria and corpus spongiosum. The tip of the papilla may be spiky or blunt and are similar to those of benign condylomas. The hyperkeratosis and particularly parakeratosis are usual. The cells are of moderate differentiation. The cells show moderate differentiation. Most conspicuous microscopic finding is the presence of nuclear pleomorphism and cytoplasmic clearing. The most conspicuous microscopic finding is the presence of nuclear pleomorphism and cytoplasmic clear cells of the koilocytic type. The interface between tumor and stroma is irregular, jagged, and rarely broadly based. In non-invasive variant, microabscess can be noted. Clear cell features persist in deep invasive foci. The nuclei are intermediate to large, hyperchromatic and wrinkled. The P16 immunostain is usually positive and useful in the differential diagnosis. The P16 stain is usually negative in the superficial or central clear cell component of this tumor and positive in the periphery or basal part of the papillae. Now coming to prognosis and predictive factors. The Warty carcinomas are moderately differentiated carcinomas usually invading corpus spongiosum or dartos muscle. The perineural and vascular invasion are unusual. Local recurrence after penectomy occur in 10% of cases. There is a potential for nodal metastasis which is present in about 17 to 18% of cases. Systemic dissemination is rare and the mortality rate is low. Now coming to Warty basaloid carcinoma. The Warty basaloid variant of squamous cell carcinoma is an HPV related tumor with Warty and basaloid feature. This tumor belongs to the family of human papillomavirus related penile neoplasm, and a large penile mass involving the glans, coronal sulcus and foreskin is the typical clinical presentation. The patient is in the 6th decade of life usually. Macroscopically, there is typically a biphasic appearance, whitish grey exophytic papillomatous tumor on the surface and a solid whitish grey to tan mass invading the erectile tissue. Now coming to histopathology. Warty basaloid carcinoma shows a papillomatous growth with superficial invasion of lamina propria of glans. Both intraepithelial and invasive tumors show a biphasic clear cell and darker cell appearance. Picture B is showing central clear cell and peripheral basaloid type of cells in a mixture of exoendophytic papillomatous Warty-like surface. These are moderately to poorly differentiated neoplasms with frequent invasion of erectile tissue, spongiosa and cavernosa. Vascular and perineural invasion are frequently seen. Warty basaloid carcinoma are more aggressive than purely Warty carcinoma and exhibit a behavior closer to that of basaloid carcinomas in terms of metastatic and mortality rate. Inguinal nodal metastases are present in about half of all patients, a third of whom will die from disease. Now coming to clear cell carcinoma of penis. The clear cell carcinoma variant of squamous cell carcinoma is an aggressive solid as human papillomavirus related tumor arising in penile mucosa and predominantly composed of clear cell. The growth pattern is in solid seeds and nests. Comedo-like necrosis and geographic necrosis are predominant. Cells are uniform with round or irregular, central or eccentric nuclei, prominent nucleoli and clear cytoplasm. There is PAS positive intracytoplasmic material. Staining for P16 is strongly positive in this tumor. These tumors are aggressive, poorly differentiated carcinoma with deep invasion of corpora cavernosa. Normally show geographic necrosis, comedonecrosis with frequent vascular and perineural invasion. Regional metastases are present in the majority of cases. Tumor-related mortality was reported in about 20% of cases. Now coming to lymphoepithelioma-like carcinoma. Lymphoepithelioma-like carcinoma is a poorly differentiated squamous cell carcinoma resembling lymphoepithelioma-like carcinoma of the nasopharynx. This tumor occurs in uncircumcised 50 to 70-year-old men. Normally occur in the glans extending into coronal sulcus and foreskin. Microscopically, tumor shows syncytial growth pattern with irregular sheets, nest, trabeculae or cord within a dense lymphoplasmacytic and eosinophilic material which obscure tumor cell boundaries. There is a minimal keratinization and cells are poorly cohesive, often isolated from other epithelial cells and surrounded and obscured by inflammatory cell infiltrate. Immunohistochemical stain useful for the identification of such epithelial cells are P63 and P16, which are usually positive in these tumor cells. In this category, only 2 cases are reported with several adverse pathological factors like invasion of erectile tissue, vascular and perineural invasion and metastasis. So, this is all about malignant epithelial tumor of penis. I hope you enjoyed. Thank you very much.